to the Virtual Global Spine Conference. My name is Ali Baj. I'm here in New York City, and I would like to thank everybody for joining us again. For those who are coming a second time, welcome. For those who are just starting, welcome as well. As you know, this is a novel endeavor and an adventure to bring people who are passionate about spine and spine education together from all over the world. And we're going to do our best to provide a safe and secure channel today to hopefully discuss some really good cases. I have a team of terrific colleagues who are helping me today, and really every time we run a program like this, they're the faculty co-hosts, and you will get to know them and see them, and I'm sure you've been following them online as well. So thank you everyone for joining us. And without further ado, I'm going to introduce the host of today's session, Dr. John Shen. Dr. Shen is a spinal neurosurgeon who specializes in deformity and oncology spinal surgery at Massachusetts General Hospital. John?
Great. Thanks, Ali, and welcome everyone. Thanks for joining us tonight. I see that people are still coming in. So tonight, the goal is we have two great guest speakers. Our first speaker is going to be Nico Sampron, and we have Dan Shuba also joining us later in the hour. But to kick things off, Dr. Sampron from San Sebastian, Spain, neurosurgeon specializing in complex spine surgery, is going to share with us some insights on ankylosing spondylitis case and also some pearls for discussion. So Dr. Sampron, Nico, please start.
Thank you very much, John, and thank you, Ali, for having me, and thanks to all the faculty hosts. It is an honor for me to be here, and I want to share my screen. Let me see. Yes, here. Okay. Can you see it?
Yes, looks great from my end.
Okay, perfect. This is a case-based presentation, and to the faculty, please feel free to interrupt me at any time. I think that these patients with the bamboo-like spine, which is a rigid spine at the same time vulnerable to fracture after minor impact. They poses real challenges to most of us. So let's get started with this case. Here's a 48-year-old man with history of ankylosing spondylitis that was transferred to our department from coming from another country. And he has the diagnosis of cervical fracture after minor trauma. This really happened like 5 years ago, but the story continues up to the present, as you will see soon. So the patient was transferred in a cast, as you can see, and he was in pain and with scattered skin lesions. He complained about pain in the posterior neck and in both arms, and the pain increased in the upright position. And he has no neurodeficits. So this is the X-ray we took with the cast still in place. And let me ask the faculty, what can you see here?
Well, Dan Shuba here. I just joined in, and I'll make comments. Obviously, this patient is you got a cast. I can see the cast on his X-ray, which I'm not used to seeing, which is interesting. But you've got this guy with a significant translational deformity, And what I mean by that is, when we think of deformity, we think of scoliosis and kyphosis. But then if you have straightening of your neck, that's in the subaxial neck, meaning from C2 down to C7, you usually don't see it. But when you have a straightening at the cervical thoracic junction, they really get pushed forward. So there's no doubt the straightening in the neck, in the subaxial neck, but based on the fact this patient's so translated that they have one of two things. One, they have significant kyphosis of the cervical thoracic junction, or they have what I would call a subjacent deformity, meaning something like severe thoracic kyphosis or hyperkyphosis, right? Because there's some patients, as we all know, who have a neck that it's that straight, but their head is not jutted forward. So what you're seeing here is that there's something that's lurking at the subjacent levels. The second thing I see is what looks like a very fused, bamboo type spine here, right? Just one long ankylosed spine. And those are my biggest two. And the third thing I'd say is this patient's chin-brow angle, the line between their forehead and their chin, is almost 45 degrees, and it's normal. It's normal to be 0 or 90. It's supposed to be straight to the ground, perpendicular to the ground. This is like 45 degrees. This patient is extremely disabled because they can't look at the horizon, they can't look up, and this patient suffers as a result of that.
Okay. So yes, that's true. And also, if you follow here the spinolaminar line, and you can see that the C1, C2, in the C1, C2 level, there is a subluxation too. Would you agree with that?
I agree.
Okay. So first thing we did is to remove the cast, and this is the full spine picture showing the sagittal kyphotic deformity that we usually see in AS patient when they are at an advanced stage. And this is a volume render of the CAT scan showing now very clearly both C7 fracture and a C1, C2 subluxation. Here is a closer look into the fracture. And here to the C1, C2 subluxation. These are cuts of thicker cuts on the CT scan. So before discussing what to do with the case, I will show you this MRI, which is consistent with an acute C7 fracture and perhaps a chronic C1, C2 subluxation, and without myelopathy in neither of the affected levels. And this is for discussion. Which approach would you do? Anterior, posterior, or maybe both? If you will approach only the fracture and you will try to fix the subluxation, so what will be your approach in this case?
Well, I'll go again first. I think you have a couple of issues that you have to balance here, right? So why is this an issue? I think part of this is an issue because this patient is slowly ankylosed their whole spine. And so let's go to the cervical thoracic. Cervical thoracic is a fracture that never healed, right? And it's hard to heal because it's too long. It's basically a long bone fracture. And it's hard to stabilize that, and patients may not heal that. Granted, when they're stabilized, anx-spon patients do heal their bone. They actually have quite a big turnover, so they heal their bone. So that's one issue. The other issue is, was this a fracture at C1, C2, or was this really just, this was the area that was the last to ankylose, and they were using all their motion because they're hunched forward. All their motion that was remaining was really at the skull and C1, C2. And so basically, this became a severely degenerative level, right? And so the reason I'm bringing this up is because when you lock those two in place, if you treat the fracture by locking it in place, and if you treat C1, C2 by locking it in place, now you're really, you're treating one problem, but you're creating another problem, which is locking this patient completely in to their position. So the question becomes, if we have to treat these C1 and C2 stability and C7 fracture, do we do a simultaneous deformity correction when we do it? So maybe C1, C2, you don't get much correction at that level. But at C7, maybe that's an opportunity to help translate the patient back, albeit this is a high risk type of procedure. And finally, in light of that, while the patient's under anesthesia, do you seek to correct them anymore? And the reason I say this is because you're balancing the instability that you want to stabilize with the fact that this patient's quality of life is terrible because they're bent forward. And so the question is, while you're there instrumenting, do you try to approach it as not only a stabilization, but a realignment procedure?
Those are excellent points, Dan. This is John Shin again. You know, we have Wendy with us, who's a neuroradiologist. Wendy, are there any is there anything you can point out to us from what you see from your perspective on the MRI and the CT imaging, especially that C1, C2 area, the area that Dan commented on? Does that look acute to you? Does this look like chronic remodeling?
Yeah, so the C1, C2, that does not look acute, either in the osseous spine, and it doesn't look like there's any cord signal. So yeah, I don't know if that was the last ankylosed that's been there a long time. If they're not symptomatic from that, I don't know the answer. The other one the other one may or may not be acute. That might be a fluid cleft. I don't know. I didn't hear if this person came in, was this a trauma or they had been in that cast for a while? That could just be a fluid cleft like osteonecrosis in the bone at that other level. It doesn't really look like an acute fracture there either. But that's just from these images. So
yeah,
Dr. Champron, did you say that at the beginning? I'm sorry if I missed it. Was this, what is your analysis of that lower level?
Yeah, we at least I alluded to that. It's not my patient, but I agree with you, Wendy, that I said that looks like an old fracture.
At the lower level.
And I completely agree with you that to me that almost looks like what I would term a Charcot spine, where, you know, a fluid collection, it's just levering and levering. It's like a long bone fracture that's never healing. And on the MRI, the patient's in a little bit more extension. And on a CT, I think the pillows or whatever, the headrest are usually a little higher. So CTs always show people a little more kyphotic and MRIs show them. And so I would argue that the MRIs are just opening up. And to your point, I agree with you. I think I would agree completely with you. That looks like an old, unhealed injury. Yeah. I agree. I would love other people's opinion, but I agree with you.
Yeah, is there,
wait. Oh, sorry, John. It's Koi Than here. Good to see you guys, Dan. So, you know, I think to address this gentleman's fracture, probably best approach from the front. But would echo Dan's sentiment that his biggest issue is his cervical deformity, the fact that he's, you know, severely cervically kyphotic and can't maintain a neutral gaze. I would probably address that deformity, though, posteriorly and not at C7, but rather at the upper thoracic spine, just to avoid some of the hand morbidity that can occur from doing something like a C7 PSO. But also interested in what others have to say.
This is Ali. Sorry, I'm monitoring the chat room here. I'm getting a lot of good questions. We're going to put our second guest speaker or presenter, who John will present later. But Dan, we're going to put you on the spot. This patient is neurologically intact. He has this fracture or two fractures. It's 8 p.m. When are you going to take this patient to the OR? It's 8 p.m. Friday night.
And the patient's status was what? Neurological?
No neurodeficit.
No neurological deficits. He's got
Intact.
fractures.
Oh, actually, he has a left side radiculopathy, but nothing more than that.
So for me, in light of some of the comments I alluded to, this would be potentially a very big operation. And I agree with Troy saying, hey, this could be a long posterior construct with potentially a 3-column osteotomy on some level. This is a first start in the morning, team, good monitoring, all my toys ready, COVID 95 mask on, best that I can get, not in the middle of the night. I just operated today on a level 1 with a guy who had 1 out of 5 in his legs, and we did our best, right? But it was in the middle of the day. This is a deformity operation with a patient who's got some radiculopathy. This is not an urgent case in my mind. In fact, it takes a lot of thinking and planning. And even before, I thought you were going to put me on the spot, ask me exactly what I'm going to do. I would want to see that Scully film again to again plan where I think I can get it, because Coy made a great point. Where am I making, ideally, if you do a 3-column osteotomy, you want to make it in one place. Most patients, you can do it in one place. In an Eng-Spon, it's one of the few patients where you might need 2 osteotomies. And so I'd want to think about that if we're addressing deformity, which I think is important.
That's a great question. That's a great answer, Dan. But also in follow-up, another terrific question from one of the participants is, in these cases of AS and basically unstable fractures, do you feel comfortable in having them stand up for Scully films to assess for the deformity before surgery?
That's a great question. I will tell you that, that's a great question. I don't know the answer. I will tell you that my experience, however, has been that the harm that I've seen in patients with highly unstable Eng-Spons have been the ones who are in so much pain that they splint. They don't want to move. And if you say you don't want to move, you got to be really careful. So, for example, a patient says, I'm in excruciating back pain with an unstable 3-column injury, and I've seen a patient brought to an MRI scanner where they went in strong and left weak, and I've seen patients positioned prone and they lost motors when they positioned prone with a sublux. I haven't seen the patients get up, because usually if they're that unstable, they do not want to get up there. They're in a lot of pain. I have seen other patients, however, who had a hairline fracture, who came to the ER. They did not x-ray them. They went home 2 days later. They were in a lot of pain. They came back and there was more of a sublux. So you're right. That's a great question. There's probably at some point they probably shouldn't be up and around. Maybe then I would still see if the patient's in a ton of pain. I'd say don't do it. If they're able to get up, then I'd try it. But very, very good point.
Just as a follow-up from the radiology perspective, that's something that we've seen as well, moving them, as you said, onto the table sometimes for MRI or CT. That can be very dangerous for some of these people, as I'm sure you know. And also, I remember when I was a fellow at Barrow, we had a case where intubation was an issue. And so you can probably speak to that as well, for how delicate these patients are and how careful you have to be with them.
Yeah, and one last thing to your point, Wendy, I think it's a great point, is that today we had this guy with a fracture sublux, and we put him in traction, and we laid him, it was a cervical, we laid him supine, and he reduced a lot, and my chief resident said, I think he's fully reduced, I don't think we need any weight. And I made the comment, traction is always great. It always realigns the spine. And as I say that, I go, except an Eng-Spon and AO dissociation, all right? Or someone who's got a skull fracture. So again, in general, traction is good, it realigns the spine. Except in Eng-Spon, you gotta be very careful. Except in skull fractures where you don't want to put pins into the brain. And the third one would be an AO or atlanto-occipital dissociation. So just in point, traction on Eng-Spon patients, to your point, Wendy, is also another concern. You start pulling this, the thing can shift and translate. Yeah.
That's great. So a lot of great points here. And I think that one of the key things is really understanding not only the biology of the bone, but also interpreting the imaging findings. So I think Wendy's input is really critical here. So Nico, let's move on. What was your approach in taking care of this patient?
Well, we decided to approach both the C1, C2, and the C7, and we did this. first an anterior approach, and it was a tricky one because in a kyphotic cervical spine, it may be difficult to reach the T1 to put the plate. So I had to remove a little bit of the sternoclavicular junction, and I did a corpectomy and C7 and iliac crest graft and plate. And I removed also the posterior arc of C1 and did cranial to T2 fixation. But any comments?
Yeah, so I think I think it's great that you address both. I think you're going to operate. I think you really should do that. The question I would have is that screw in C1, is that into the condyle of 1? Is that on purpose, or does it just look like that because it's long?
No. I think it's mager transarticular C1, C2, not in the condyle.
Got it. Because I was going to say, if that's the case, I want you to teach me that, because that's a pretty awesome maneuver, is to go all the way to the skull from the back. That would be sweet. The other question I had was the need to go to the skull. Tell me about that. Was that an anchor point question where you wanted to have more anchors, or was it that did you feel like he was unstable? Because it's obviously even though it seems just one more level, obviously it's a big step to be occipital cervically fused, because in essence this guy now has occipital down to tailbone, if you will. And so was that needed? Do you feel that was needed for anchors, or did you feel like you were worried about instability occurring there, or was there already instability in your mind? Just your thought process there.
You mean the process to include the occipital bone?
Yes.
And the,
yeah. What was your thinking to
I
go
thought
to
in this case, to my knowledge, it's not like a fracture in another patient without AS. So you have to go 3 or 4 level ups and 3 or more down. And then it looks like to put additional stress to C1, C2 in a condition with a chronic subluxation will be a problem. So that was my idea here.
Okay.
Nico, it looks like you got a really great result with at least restoring the, from what we can tell on these images, the horizontal gaze here. The question that I have is, maybe can you give us some insight in terms of how you determine your lowest instrumented vertebrae there in the thoracic spine, in terms of stopping where you stopped versus going lower? Is there, I know it's a pretty tough question, but just in the last couple of minutes we have for this case, is there any insight that you can provide us?
Yes, really, in this case, because I was, we have a corpectomy and a good bone graft in the anterior approach and a plate. I did only 2 levels down, but I'm not happy with that, and we'll probably go a little bit more down nowadays. But the case doesn't finish here, because 5 years later, this was 2 or 3 weeks ago, during the COVID-19 crisis, he presented again with this.
My question, Nico, is after all these years, how did this patient find you again?
Oh, the patient was doing really well, was really happy. And this, by the way, is 2 years after the surgery. And here we discussed the possibility of deformity correction surgery down in the lumbar spine, but finally we didn't do it. And so he came back to me 3 weeks ago with this fracture.
So Nico, what did you do? Did you extend them down, or did you do a separate construct?
What would you do? What would you do in this case? So I think that the point to discuss here is if we should go an anterior, posterior, or both approaches. How many level ups? If we need to unite the previous surgery with this new surgery, if this is finally a really good opportunity for deformity correction.
Yeah, I'll just chime in a little bit. So it kind of brings up the point we originally brought up. Is this giving you a chance to improve his subjacent alignment a little bit? The reason that I made the comment about 2 osteotomies is because sometimes what happens is if you don't think about them. For example, we've seen some patients who've had. Let me just say, if you correct this where you bring his head back significantly, but you've made a pretty good chin-brow angle with your OC fusion, meaning that your OC fusion has given you some kind of chin-brow angle that's good to the floor. If you correct a lot below and you pull him back, he will now be locked in looking up. So the question becomes, and that's why, thinking about it, these are so tough because they don't give you any freedom. So I think probably getting some correction would be reasonable. Trying to completely correct him is morbid, but it also may actually offset the chin-brow angle that you set up at the top. It may put him up. So I think I would use what it gives me, but not do a massive correction. All from posterior is a thoracic fracture. You do not have much control in the front. You need multiple anchor points, a posterior approach only.
Yeah, I'd agree with Dan. This looks like it's a P12L1 injury, so something like a, T10 to L3, all posterior fusion. To me, it doesn't make a whole lot of sense to correct a predominantly upper thoracic deformity with work at the thoracolumbar junction. But would agree that going for a little bit would make sense.
So my idea here, I agree completely. My idea is to go only from posterior and to fix this insider. So to take the correction that the fracture is doing, but not to add any more correction. And this was done in the middle of the COVID crisis, and it was an emergency surgery, but I'm not really happy with the result, as you can see, because of the here and T12L1, there is a quite significant gap.
The question that comes up, this happens with what you call, for people in listening, we call these opening wedge osteotomies, right? As opposed to closing wedge osteotomies where you make a triangle and close it. This is an opening wedge osteotomy where you cut and you're levering really in the middle column. So what happens in these is Angstbahn can heal if the posterior decompression, if you did any, was not too much. So if you have a big gap in the front and you have bone on bone in the back, you might be fine. If you have a big gap in the front and you've done a wide laminectomy with any facetectomy, then you might be concerned that you have to fill that. But if there's bone hitting in the back, you may be okay with that. But obviously, to fill that front, you'd have to do a thoracotomy or an extracavitary approach from the back. So, which are reasonable. But I would say if you have bone on bone in the back and the screws are macho with that cement, you might be covered and it might heal in the back.
Yes, I'm not sure, but I put the patient in a brace, and I present the case to complete the surgery with a mini open anterior approach to put something in the gap. But this patient was not prioritized because of the COVID problem. So he is currently home with a brace, and now I will propose to complete the surgery with something from the front.
And just a kind of learning point for me that I've experienced in the past is that if you want to fuse an Angstbahn in situ, meaning that you do not want to do a deformity correction, I find that naturally with Angspine, they are often very globally kyphotic. Putting them on a Wilson frame or some kind of a kyphotic type frame is safer, because if you put them on a Jackson, they can fish mouth and translate. However, if you want to have a significant deformity reduction, then you can put them on a Jackson. One thing that you can do in between is you can put them on a Wilson frame, and then in the operation, you can crank down the Wilson frame and let them sink into more lordosis, if you will, and that way control the spread. That's something I've experienced because I've learned. I had a Angspine L4 once, and I saw a sublux on a Jackson with a big fish mouth, and it was very hard to control in the back. That was years ago, and I learned that trick.
So Nico, you said that you did that anterior approach, or you're planning to do it?
No, I'm planning to do it.
You're planning to do it. Okay.
As soon as possible.
Well, that's a really great case and great discussion. Any final thoughts, Nico, that you want to impart?
No, I just thank you for your comments, and
would you like me to start showing some slides then, guys?
Sure. Yeah. So let's see here. I think, Dan, you should have the ability to do so.
So I hit share screen?
Yeah. So just as we segue, that was a great discussion. I mean, we could talk about that case for another hour, it seems like. But just in the interest of time, we're going to move on. So it's great to have with us Dan Schuba from Johns Hopkins. He's a neurosurgeon, complex spine surgeon, very accomplished. And it's a great pleasure to have Dan sharing some of his insights on some tumor work with us. So Dan, whenever you're ready, feel free.
Okay, so I'm going to try my best here to share. Can you see anything?
Yes.
Is it a PowerPoint or is it the sub PowerPoint? Is it like my view? Oh, no.
It's your view. You just have to go to presentation mode.
Can you see it now as a PowerPoint?
No.
No.
Do you see it as the non-presentation view?
No, it's just something is really zoomed up on your screen. It says slideshow. You may want to just click on that.
Oh, this one.
Yeah, there you go.
Sorry about that. So real briefly, I wanted to thank the whole host, Ollie and Coy and John and Nico, the co-moderator Wendy. I mean, this is a really great service. I've done a lot of Zoom talks, and I think this is going to stay, guys. And I think that you're pioneers in this way, because all of us are now jumping on around the world. And I just want to thank you for doing this. This is fantastic. Secondly, if it's being recorded, then it becomes a nice library. So thanks for doing this. So I'm here in Baltimore. I'm actually in my office. I'm operating today. I've kept I've actually operated regularly here because I have a lot of tumors on my service, and they're hard to talk out of doing surgery when they're weak. So I'm just going to briefly give a little background. There's the intramedullary tumors in the spinal cord. There's the tumors that are inside the dura but outside the spinal cord. And there's the tumors that are outside the dura. I'm just going to briefly talk on these today, okay? I know we can go forever, but these are the ones that are the most common if you count in all the metastatic lesions. And so I wanted to just talk about these. And I'm going to present two cases. One is going to be a primary, and one is going to be a met. Okay, so here's case one, 73-year-old lady. She's an ex-professor at our institution. She's got bad back pain, decreased ambulation, mainly due to pain, but also some myelopathy as well, and some weakness in hip flexion. So some myelopathy type picture. Sensation, blah, 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 and maybe a little clonus. So anyone want to comment on these images here?
Wendy does.
Will, if I can see them again. It looks like, so I'll talk until you get that back, until you get that picture back.
Can you see it there?
Dan, it kicked out of your slideshow.
Oh, I'm sorry. How about now?
There you go.
There you go.
I'm going to give you a close-up there, Wendy.
Nice, thank you, I need that. I need to get real close. So you have just a complete collapse of that vertebral body with, looks like It doesn't even really look like bone, but it's probably a combination of bone and tumor and hemorrhage going back into the canal. On that first image that you've got covered up, yeah, so that looks like maybe some, epidural enhancement. You don't have a lot of cord compression, although in the thoracic spine, that's not as important since the cord is kind of fixed there. Probably epidural, spinal cord, 1C, 1B, something like that. But in the thoracic spine, I'm sure that's more symptomatic than it would be elsewhere. Just a little bit of listhesis. You haven't lost too much alignment. Certainly, though, you've got involvement of the whole vertebral body, the posterior elements, all those aspects that we look for in the SIN score to give a grade of how unstable that fracture would be. Anything else there? It looks like the rest of the spine's okay, though.
I think you're right. And she's obviously older and has some changes in terms of degenerative changes. But just two things to comment on. One comment is you said a 1B or 1C. Just for the listeners, she's talking about what's called the Bilski grade, which is how much embarrassment or compression there is on the thecal sac. I do not have that grading scale in my talk, but that's something to bring up. She also talked about the SIN score, which is the spinal instability neoplastic score, and I will touch on that. So that's helpful. I'm so glad that without knowing each other, you and I were simpatico on that. I'm thinking the same thing. So I'm glad to hear that. So no other tumors identified on a staging study. Staging studies are CT scans of the body or PET scans of the body. People always say, Dan, what do you want, a CT chest, abdomen, pelvis, or a PET scan? And the answer is surgeons usually order CT scans because they're anatomic. We can see very fine details, while oncologists usually order PET scans, which are more of a screening test. And so the answer is either. And I'll say that if you do a PET scan and you find something, I still may want a CT scan to look more clearly at it and zone in to see more detail. And if I do a CT and I just do the chest and abdomen, you might want a PET scan to look at more if needed. So that's something that people ask, and I'm hopefully cutting that, answering that question before if you're thinking that. So the next step, I don't know if we have the ability, but maybe you can look at just as people chat in, is the next step a decompression fusion from the back. In your body there, you want to do kind of a corpectomy from the back, maybe an en bloc corpectomy, take the whole thing in one piece or in piecemeal. Do you want to do some more testing, some more serum testing, some more biopsy, or just the biopsy itself? In other words, do you want SPEP, UPEP, which is really markers for a myeloma, for example, or you just want to go right to the biopsy? So Ali, I know it's a kind of quick and dirty, but maybe you can comment because I don't have the chat open. What are people chiming in, or what do you think, or what other people think?
I'm going to go ahead and activate that. I'm keeping a close eye. It looks like a lot of E's and F's. A lot of E's and F's.
I love it.
A lot of E's.
A lot of E's. A lot more E's than F's. Yes.
So I don't know if the people on the call are younger than me, but the people, if they are, what you guys all do well, that much better than I did. When I was younger, I would just be like, let's go, operate. And the smarter younger generation, or just the smarter people than me, always say, I want a little more information. And in the setting of this patient who's not drastically declining, more information can be better. If they're drastically declining, I might say, come on, you gotta do something. But I think that a biopsy is a great idea. You have a solitary lesion and no other lesions else in the body. So we did a biopsy, and the biopsy came back as chordoma on this lady, okay?
Dan, I'm sorry to interrupt. Just fielding some questions here. If you go back to your options, there are a couple of participants, maybe a little bit more, who it shows the surgical option. And I think this is a key point of this talk, and really any spine tumor talk. Can you just highlight again for everybody why you would not recommend going straight to surgery?
Great, thank you. No, this is the key point on a solitary. So let's play this out in two ways, and I'm going to show this in my second case, but I want to set it up now with Dr. Baj's input. If you have someone who's rapidly declining neurologically, that is the most important thing, because anything else seems secondary to that. If someone is unstable, that might be the most important thing. In this patient, yes, they are unstable. Dr. Gibbs may suggest to me, hey, this is an unstable because there's components here that suggest this is unstable. meaning that I don't want to let them do nothing. But there's a difference between what I would call overtly unstable, like a fracture sublug jump facet, and someone who's got a spondylolisthesis of 4 or 5, which in theory is mobile on flexion extension x-rays. Both are unstable, but one is walking around and the other one is probably in traction or in a collar. And I would argue this one is closer to a little bit more, or at least not overtly unstable, because she's not in excruciating pain and she's not declining rapidly. Therefore, what we have to then leverage against that is the fact that if I run into this case, and this is a primary tumor such as a sarcoma or chordoma, I've missed my opportunity to cure this patient with surgery by doing a more aggressive, more well thought out, more planned, surgically oncologic resection, meaning that not getting into the tumor and not spilling the tumor. And I want to make that clear because the second case may be a little different than that, and I want to think about that. But if you have a solitary tumor, no other tumors elsewhere, in theory you can cure this patient if it's a aggressive tumor. Now, what always comes up, but what if they're declining? What if they're getting paralyzed in front of me? I will tell you my experience. I often don't see chordomas or sarcomas of the spine presenting with high-grade compression. I have a handful, maybe 3, and maybe on one hand I've seen it over the last 10 or 12 years. So not as common. Don't rush into them if the patient can get a biopsy and think about it. Anything else, Ollie, or anyone else, if I made that clear, did not make that clear? Okay. So comes back chordoma, and this is part of the issue is now, if people know it's chordoma, does this change what you do? So I might have let a little bit of my biases out, but if you know it's a chordoma, does this change your mind? So now start voting again and see, with a letter maybe, and Ollie can just with his rapid response be like, I see a lot of A's, I see a lot of C's. You don't have to write a whole paragraph, just, a letter maybe.
So we have a unanimous vote for D.
Oh, so thank you for at least indulging me with what I think might be the right thing. Maybe doing something big. Okay, fair enough. Why? Why would we do that? These are some papers showing, and you don't have to read all these things here, all these words. That's confusing. Just look at the line. In a lot of these sarcoma studies, if you have more of a surgically oncologic, meaning if you take the tumor out without contaminating it, because these are locally aggressive, you can affect the survival or the local recurrence, whether it be sarcoma or other sarcomas or chordoma. So this slide, in essence, is the argument for why I would suggest going bigger, because if you don't go big, you may be on the dotted line. And even though we have better and better medicines every day and better radiation every day, unfortunately in 2020, still a lot of these diseases are still surgical. You get them out in total, that is better than not. So this is why we leverage the patient. I want to take more time and get a biopsy to try to offset it. So this is the patient. They had a posterior approach first, and here you can see stabilization above and below. And this is an aggressive lateral extracavitary approach bilateral. So this is pleura. So these are ribs removed on both sides, okay? Not lung, pleura, okay? Not spinal cord, dura, right? So we have, at least on this case, maybe one of my cases without CSF, I don't know my case without, but you're trying to stay outside the dura. So you always say, is that the spinal cord? No, it's the dura. Is this the lung? No, it's the pleura. That's the important point, is that you're trying to stay extracavitary. Transcavitary would be going into the chest. We're trying to say that if you get into the chest, so be it. It happens. You got to be able to handle it. We can talk about it if you want to talk about complication management, because I've had plenty of experience with creating complications and trying to manage them. And this is the idea, okay? So we cut out the posterior elements using, at least in my hands, I use an ultrasonic bone scalpel, and I cut these out. And then we spend a long time dissecting around, cutting the segmentals, dissecting off the aorta and the vena cava from the back, both sides, developing an epidural plane, and then amputating the pedicles and rotating this out. And here you see it. All right.
Dan, just a quick question, if I may interrupt real quick. From the chat panel, 2 very good questions. Number 1, how do you truly avoid tumor spillage? And number 2, is it a true-on block if there is epidural extension?
Yeah. Okay. Great question. Great question. So the first one is probably, simply put, very carefully, if you have, in terms of can you avoid spillage. So first off, if you have a margin that's sacrificable, meaning that you're in the tailbone, you can go up a little higher and cut out more sacrum, Do not ever come close to the tumor if you don't have to. And I would argue that this is what the ortho-oncologists do with extremity tumors, where if they sit there and say, do we have to cut below the knee or above the knee? Do we have to take the whole leg? So the issue is if you can take a good margin and the patient doesn't change in terms of their prosthetic, take more. Same thing in the spine. You can take more bone. You don't want to be anywhere close to tumor. That becomes an issue, as you alluded to, as you get into the epidural space. Because now your margin is what we call a marginal margin. It's not a wide margin. It is not a radical margin. It is a marginal margin, meaning that the margin is just tumor against dura. So the question becomes, the question that was asked, and I want to do about terminology, is it truly en bloc if it's already an epidural? And the answer is the term en bloc means one piece. So that's what en bloc means, one piece. So I can take this tumor out in one piece and have gone right through the middle of the tumor. Okay, so en bloc, what you really want to do is you want to do en bloc and negative margin or marginal margin. So when people say, I did this en bloc, I go, yeah, you did en bloc, and you went through the middle of it, and it's en bloc, but you left half the tumor in. So en bloc by definition is not we want en bloc and a negative margin. So the answer is, when I want to clarify en bloc, and number two is, yes, your margin is marginal. And so if there is spillage or if there's intimacy with the dura, that's where it's going to recur in most cases. But what I found is if you don't spill it, my experience is a lot of tumors occur in some of the bone, say in the sacrum. If you make cuts in the sacrum, it recurs in the sacrum or the gluteus, but not necessarily in the epidural space. Anyway, did that answer that?
Dan, I think that was great, and we have a follow-up question that's really even better. I mean, these questions are phenomenal. This is about how often do you require a pre-op angiogram looking for Adamkowitz if you're doing a spondylectomy at the thoracolumbar junction?
So I will tell you that I use my interventional radiologist routinely. I used him yesterday. He said, was it urgent in the setting of COVID? I said, yeah. So I had a renal cell plan for today. And he's going to now be pushed to tomorrow because of that fracture sublux I did. The issue is I like using interventional radiology for vertebral artery evaluation. I have yet to use it for Adamkowitz. The question becomes, can you take Adamkowitz? The question that comes up is, as surgeons, we often don't encounter it, the interventionalists do. And I'll tell you, because the interventionalists care more about it, because when they block it, they usually send particulate matter distally into an end artery. So what they don't want is they don't want to clot off a radiculomedullary artery and potentially have embolic material go deeper into the artery that goes to the spinal cord. On the other hand, when we clip Adamkowitz or a radiculomedullary, usually there are other feeders that are more distal to it that don't hurt the spinal cord. That being said, do I sometimes take the artery and put an aneurysm clip on it and run a motor for a few minutes? I think a lot of us have done that for osteotomies or en blocs, and knock on wood, I've never seen it change my management, and I've always taken it. The most I've ever had with a spinal cord injury from vascular is when I took 3 segmentals on a young man, and he did fine from that, and 2 days after surgery, he was in a lot of pain. They gave him medicines. His blood pressure went down to 50/20, and he was getting sleepy, and he said his legs were getting weak, and his blood pressures went up, and they came right up. So I think the only time I've seen it is when someone's truly hypotensive, and maybe in that case, they have more of a watershed area in their spinal cord. So the answer is I do not do an angio, and then the next question is, do you then interrogate forward or put clamps on it? I'm doing it less and less.
Dan, when do you decide to place anterior column support versus rely on multi-rod constructs?
So as you'll see, I'll put a cage in this patient, and this was an older a patient I did maybe last year. I'll show you what I did. But these patients always get reconstructed anteriorly, whether it be placed from the posterior or anterior. So I did a chordoma on Monday that was an L3, and that was done posterior stage 1, anterior stage 2, reconstructed with an anterior construct in stage 2, because I couldn't put something in from the back. Thoracic, if I'm going to go off on the back, I'll shift it around, push on the lung, and drop it in from the front. So if you're doing a full en bloc, it's always going to get a strut anteriorly, whether it's placed anteriorly or it's placed posteriorly. And maybe I have a picture of that. Here's the specimen, and here's the cage. And this lady was old, so she got cement at every level. Here's a cage. I often do not do distractables, but when I'm working from the back, these are easier to put in. If I'm working from the front, they get I don't have it here on this talk. I'll put a big mesh cage filled with bone so that they heal. I always want them to heal their bone. I think this lady, because she was older, I thought, I don't know what I thought, but I often don't do distractible cages because they don't heal as well. Okay, for the sake of time, I'm going to move on. If maybe in 5 minutes I can get most of this done. A little bit different. Case 2, a 70-year-old. Now, it's different, right? This is now, I'm going to, you know, when you start writing test questions, when you get old like me, every word matters. Rapidly progressing myelopathy. 3rd word, 4th word, whatever it is. Rapidly progressing myelopathy. So if you're a good test taker, you know that this was meant to be put there on purpose. And you know, if you're presenting this to a colleague, you're going to say, I got a patient with rapidly progressing weakness. You're not going to say, I got a guy with a history of diabetes. You're going to say that. This is now different, right? Now in wheelchair, balance, all declining, 50-year-old smoking history of prostate cancer. 2 months ago, now with known mets to the bone, unable to stand, weaken the shoulders, weaken the biceps. Okay? Here's his x-ray. Wendy, the quick and dirty on that.
Looks like you got some anterothesis of 2 on 3 in addition to your, well, it looks like a fracture there, right? And this kind of a wedge plus some fracture lines through there in C3. It's not sclerotic like the ones below where I would have guessed the Mets were, but maybe if that's one of your levels that you knew had cancer, pathologic fracture. The posterior cortex looks intact, but it looks more like trauma than pathologic fracture, but okay.
There's more.
Yeah, so these lower levels, those look more like cancer on the other scan. Just the quality of the bone. So those look like your problem right there with the epidural extension of disease, lifting up the ligament, getting some cord compression, a lot of cord signal. And on your axion, okay.
Let's see. I think this is contrasted. I think.
Yeah.
Yeah.
So yeah, those lower levels are the problem there. It looks like there was some sublux up on the 2-3 before, but I guess that wasn't real. So it looks like those 2, 3, 4, 5, 6 are your main issue there. Maybe 3, 4, 5, 6.
Here's some more.
Now you've got your cord compression, your epidural spinal cord compression here. Maybe we have to do it on a T2, not a post, but maybe that's a 2 or 3. So that's not going to be able to be radiated. You're going to have to go in and get that tumor out of there if that's a tumor amenable to SRS. Oh, sorry, I gave away.
I agree with everything you said. So now it's a different presentation, right? It's a patient with many levels. Wendy could write probably about 10 pages on this patient, you know, if she wanted to. Just, you know, C4 and C5 and C6 and C. It just keeps going. Patient's got known mets. Patient's weak. So I don't want to bias you, but is this some patient who? Oh, and by the way, known prostate to the bone. Okay, so now tell me give me some letters. It's like I feel like it's like roulette. You guys are all putting your money on a number, you know, and Ollie's seeing what the bets are coming. It's like the stock market. Who's it bets? And
yeah. So it looks like we have a little bit of variability. A lot of people are choosing F. Yeah, I think more Fs are coming through here. An occasional H or J, an occasional H actually, but mostly F. Fs and Hs.
Okay, so people they don't want to do a stat biopsy, it sounds like. C.
Right, they want surgery.
Because a stat biopsy, even at our center, I think we do a good job. Even if you ask for it stat, it's a couple days at best. But usually it's a week if you don't ask stat. So now you're sitting there saying the guy, so you're not going to wait on this guy. You're not going to say, is it prostate? It's a different combo. And we're not going to en-block this guy because he's got tumors all over the body. And it's like whack-a-mole. You take this tumor out, he's got tumors somewhere else. I don't know if people in other countries know what whack-a-mole is, but that was where you had a video game where one pops up and you hit it and then something pops up and then you look over. So the issue is that you're not going to want to say, I'm going to treat this patient, get every single tumor out with surgery. It's not really a surgical lesion other than, it's not, let me take that back. It's not an oncologically surgical lesion. It's a stabilization and decompression. Here is the NOMS framework. It's one of the many frameworks. It's something to think about, guys and girls. It's complicated a little bit here. The idea is you got to think about neurology. Are they weak or having problems walking? You got to think, is this tumor something that's sensitive? Radiation, because that might change. I did a lady on Monday who was myeloma. They knew it was tight. They didn't do anything about it. She came in, or it was COVID and all that stuff. She came in with, couldn't walk, and I had to do a surgery on her. If she'd been radiated maybe the week before, maybe no surgery. Mechanical, is it broken? It doesn't, radiation doesn't help someone who's got a broken neck. Got to put screws or something in. And then are they able to tolerate surgery? Are they very, very sick? Whoa, a lot of words here. Don't know why it's so big. This is probably the most important. SINs, Wendy talked about this. Again, it looks complicated. These are the numbers you add up. But the idea, again, is you've got to put a premium. If things are at junctional levels, the more junctional, the more unstable they can be. If the patient complains of a lot of pain, more unstable. If it's lytic, obviously it's more unstable probably, right? If it's subluxing, more unstable. If it's collapsing, more unstable. And if the posterior elements are involved. It's some combination. It's probably not in reality as linear as we think. It's probably not just a set. It's probably a non-linear equation where some things are more than others or they magnify each other. Nonetheless, this was a paper that we put in together years ago. An idea is this is a little bit on probably what most of us agree now is if you're 10 or above. If you're 10 or above, you're going to get surgery. And if you're 9 or below, you're going to probably avoid surgery in most cases. So in this next step, I think what I got was a CT to look at, because that's quick and dirty. A little hidden in there. No one said D. Quick and dirty is CT. No one said that, but I wanted to, because I wanted to know, do I go anterior or do I go posterior? Because this is so eaten away. And this is what I got. Wendy, quick and dirty. I know I keep giving you more imaging every time you read one. I give you another one.
What am I looking at here? So these are just kind of go off to the side. Is it the same view? Your C2 looks the same in each of these pictures, so I'm not sure what I'm looking at, but you got
a millimeter cut. Yeah, you're right. They're all the same basically, but mid-sagittal, a little off mid-sagittal. Yeah, same stuff.
So I mean, you got your path fracture here in 3. You got your sublux here at 5. I'm not quite sure in terms of a SIN score, probably not high enough for surgery, I bet, even though we're not seeing posterior elements. But that doesn't mean in this case that you wouldn't go in, that it's not unstable. Or it might not be unstable, but you're still going in there because of the cord compression.
Right. Or if you did a posterior operation and you take out the posterior elements, and now you've got those crappy looking levels in the front, maybe you do change your SIN score, right? If you'd almost artificially take away the posterior elements and say, well, now with a laminectomy alone, now you're really screwed because you got these bad. So yeah, something to think about. I agree your point. Like maybe individually, not as bad as it has to be, but you're right. So does it change anyone's thoughts? Ali, a quick and dirty, we're getting you to the end, so I don't want to keep it going, but does anyone change more to, are they now more posterior? Are they now more anterior? Are they saying, oh, I don't mind about this thing, and I don't mind about that. That looks plastic. Oh, I don't mind about this in the front. I can make this patient more orthotic. I want to go in the front to do cages. I mean, just see, are they doing more anterior? Or are they sticking with posterior?
Got it. So we'll throw that question out there, but it seems just in summary that this patient has widely metastatic disease. Is that correct?
Yes.
Do we, somebody asked this earlier as we accrue more answers. Somebody asked, how do you determine prognosis or life expectancy when you need to make a rather urgent surgical decision?
Yeah. So there's a number of systems that are out there about trying to predict survival. And I've been fortunate to help contribute to literature on those in some ways. So I have some thoughts, but they can get kind of heavy, and you can't predict the future. So what I would distill all that thought and all my experience into a couple things. You have to put yourself in a position to talk to the patient about, are we doing an operation on you? And does your window of survival, at least based on the best information we have available from your oncologist, your medical oncologist, and where you are in your disease, such that when you dip with surgery, is there enough time in your life that you're going to benefit from the valley, the mountain that comes back? Because the patient might be here, and if you're going to take them on surgery, you want to be able to see some benefit. If the patient's going to die here, you've made that patient's quality of life worse because they actually died when they were still recovering. So for me, the situation becomes, if I think this patient can handle a surgery that's probably going to get them through a recovery, they probably need on average around 3 months. The oncologist will not tell you that. unless they think the patient truly is going to die. Because the oncologists, in my experience, do not want you not seeing the patient. If they say, we think they're going to live that long, the surgeons will say, why'd you wait? Why'd you call me? So they always say, I think they could benefit. You decide what to do. If the oncologists say they are not good for surgery, the patient is likely going to die, in our experience, at least in Baltimore, within the week. If they say the patient's not going to live that long, and I say, really? Those patients usually die in a week or two. So when they say patient might not live that long, it's usually 3 or 4 or 5 months. This is the issue you want to avoid. If you don't operate on them and they get paralyzed, that's what you're balancing between surgery and an issue. So the long and short of it is we have a number of factors. We're putting out a review paper on all the different classification systems, and we're getting better. There's serum markers if their albumin's down. And then there's finally the good old-fashioned eyeball test. If you walk, this sounds terrible, but if you walk into a room with someone with cancer, and maybe I'm not the best example, but if you look at me and I tell you I have widespread cancer, based on how I'm acting and my energy, you might say, Dan can handle a surgery. If you see me and I'm all pale, bruised, I'm on nasal cannula and I can't breathe, it looks like I have terminal disease. Probably I'm terminal. So you have to be honest. If you look at the patient, you say, I think you're getting close. Your gut and your experience as a doctor helps guide the way independent of the classification systems. That was
that was helpful. And obviously from your answer to this, what's clear that it's a very complex answer, right? It's not a straightforward decision-making process, but I will tell everybody, the participants with us, for a lot of centers that do this, unless it's an emergency, this is really a multidisciplinary issue. You've got to establish good relationships with your oncologists, your radiation oncologists, not the day of or not at 2 a.m. when the patient comes to the ED. You have to proactively, discuss cases at tumor board and have a good rapport with each other and with your colleagues. That's something a lot of us have learned, sometimes even the hard way, but it's very critical. Just real quick, for the sake of time, it's basically a unanimous F as far as what people would do. Posterior decompression instrumentation is what almost everybody said except what you did.
So I got it wrong. So we crowdsourced and I got it wrong.
Everybody said F.
So I was worried. This is my explanation for getting this cancer wrong based on the crowdsourcing. Oh
no, a few people corrected me. I have to admit there are a handful of J's. A handful of people agreed with you, but it was overwhelmingly an F.
The J's are trying to make me feel better. Thank you to all the J's out there. So the reason I thought this was I was worried that he was going to have not a good enough purchase in the back, and he was starting to be kyphotic, and God forbid I put screws in the back, and there was this big hump here, and I didn't get decompression, and I thought I'd stabilize it, take it, and I like anterior approaches. That doesn't mean that, I like anterior cervical approaches. They do well. So I did this. Then I felt good that I decompressed all that junk, and then I backed him up. And since he had I didn't show you all the axles. He had a number of lateral mass areas that could not hold screws. I think that was another part of my issue, was that I couldn't put an anchor here. I couldn't put an anchor here or here. So I said, oh, it's going to be like 2 screws and 2 screws. I couldn't even put them where this was the area that Wendy said, the upper thoracic area, where there was more tumor up here on that old scan. So I just said, this is not going to be enough. It's going to look too weak. People are going to say, would you run out of screws, Shuba? And I'm going to say, no, I had no anchor. So I put it in the front to double it up. And then I also put cement. This is how bad his bone was. I put cement anteriorly and then drilled a hole into the cement so I can put anterior screws because his bone was so weak. So this was really kind of a wimpy bone substrate, and I didn't want it to fail, because if it failed, it would not do well. In fact, in tumors like this, unlike a fracture, unlike the Yank spawn done by Nico, you put them in a collar, they don't necessarily fuse, ever. These patients are going to be radiated, and they don't necessarily fuse. So putting them in a collar means you're basically keeping them in a collar. So for me, I said, go big right off the bat, lock this and lock in the back. So thanks for the J's for agreeing with me. But I wanted to add in one more point to Ali's point about multi-D. I take it for granted because a long time ago, I learned the hard way that I was on an island when things didn't go well surgically. And I'd say, I thought this. They'd say, why do you do that? And I go, man, I was by myself and I thought a lot. I thought a lot about it. It was probably not the right call. If you have a multi-D conference, that's great. But guess what? The multi-D conference doesn't meet with you on Fridays. But what it does do is it takes care of the non-urgents. And then when you have an urgent, you have now friends that know you, and you can call quickly and say, what do you think on this patient? And then they can say, I think you're stuck doing surgery, Dan. And if surgery goes well or doesn't, you go, hey, I have multiple people agreeing with me. And they say, that patient is so sick, I think you're going to hurt them. Then when I say to the patient, I don't think it's the right call, I can say not just Dan Schuba feels that, but we as a team all thought that was the right thing to do. And the patient likes that. I like that. Everyone likes that. No one's caught off guard. It's the right way to do it. And Ollie's point is well taken. Totally should be stated multiple times.
Great. I think for the sake of time, we'll have John close things up. Dan, do you mind closing your screen share, Dan?
Absolutely.
That was really excellent. Thanks, Dan. That was a tour de force kind of review of primary and metastatic tumor management through two very challenging cases. So it's always a great exercise to go through the thought process and to hear sort of how, you know, you and others kind of go through that. So, and again, thanks for everyone. Thank you, Nico, as well, for participating and volunteering tonight. I think on behalf of Ali, myself, Wendy, Jonathan, Coy, and Griffin. I don't think Griffin was on tonight, but on behalf of everyone, we're really happy that you're with us. And I think we have recorded the session, and we'll find a way to archive these. So, we're really happy to see everyone here. We did just recently start our own Twitter page, so I just wanted to plug that as well. It's @virtualspine. And please follow us. We'll make announcements there as well as through email, but we're really going to try to have our communication through that channel. So thanks again, everyone. Ali, Wendy, anyone want to have any other thoughts? But I thought it went great and appreciate everyone for participating.
Yeah, absolutely. Thank you, everybody. Wendy, Jonathan, Griffin is one of our colleagues who put this together. And as we speak, he's a neurosurgeon who is covering the ICU COVID unit. So we thank him for what he's doing. And really, I think a lot of you guys are in that position. So most importantly, just stay safe and thank you for being passionate about this with us. Next Thursday, we have two terrific speakers. One of them is one of our own hosts, Dr. Wendy Gibbs, who will talk about some pearls, radiographic and radiological pearls in cervical spine. And we also have, of course, the world famous Dr. Todd Albert, who's a phenomenal colleague and orthopedic spine surgeon at Hospital for Special Surgery. He'll be joining us next Thursday and talking about his extensive experience in anterior cervical spinal surgery. We will make announcements online if there are any additional sessions. We may have one on Monday, just depending on what the feedback is. But that is also an option that we could have an additional session, what we call a QA session with the speaker or with the presenter for those who want to do a deep dive into a specific topic. So without further delay, thank you everybody and have a safe and wonderful evening. Or for our folks across the Atlantic, have a wonderful morning.
Great. Thanks, everyone.
Thank you, everybody.
Thanks, guys and girls.